How would the opioid epidemic have played out in an ideal health system? I'm Dr. Chad Swanson, and I'm an emergency physician. I'm on a journey to understand and transform our health system. I'm actually outside at a park. It's a beautiful day. Our hospital has sponsored an annual community carnival-like setting with some health fairs and other things, and I think it provides opportunity for social connection and getting outside and walking around, exercise, all of which improve health. So I think that's great. I'd like to take a moment just to summarize my understanding of what happened with the opioid epidemic over the last decade or more under the current system, and then maybe imagine a little bit how things could have been better and different with an ideal system based on a shared vision of health and well-being for all at the lowest possible cost, with a complex systems paradigm and incentives aligned with that vision. So I'll use an imaginary primary care clinic for this exercise. So a patient arrives at the primary care physician's clinic, and she has had chronic pain for years. She initially twisted her ankle and had a prescription for opioids maybe 10 years ago, and then became addicted to them. And so over the years, she would come into emergency departments and her primary care doctor and receive prescriptions for additional opioids. The primary care clinic is very busy, and so the easiest thing to do is to provide the opioids. There was also a mistaken understanding that opioids weren't very addictive years ago. And so this patient, imaginary patient, continued receiving opioids, which affected her life, affected her ability to care for her family, affected her ability to work, affected her well-being and her overall health. In the clinic, the main drivers were episodic treatment, so the treatment of the individual in front of the provider at the time, and as well as obviously financial rewards. And so the clinic was rewarded financially for the number of patients that they saw, and so there were incentives to see as many patients as possible. This patient then went on to use heroin and fentanyl, and that in turn affected her family members and friends, and some of her acquaintances and loved ones also became addicted to opioids because of her unintentional influence on them. And that in turn affected their community, and this played out throughout the country. Of course, in the background was pharmaceutical companies that incentivized and advertised in ways that glorified and focused on the benefits of opioids without adequate consideration of the downsides. There was research that was misrepresented. And so that's more or less my understanding of how things have played out over the last 10 to 20 years. And it's really been a tragedy, and as a current emergency physician, I've seen that play out hundreds of times with my patients, maybe thousands of times. And then tragically, I've also seen it with loved ones who have passed away in my own personal life. Let's imagine a scenario now where there is a driving force, a powerful force of a shared vision of optimal health and well-being for all at the lowest possible cost. So let's imagine a clinic where this same patient comes in, and instead of being incentivized to see as many patients as possible, this clinic is incentivized to make patients as healthy as possible. And so they actually have to utilize more of their resources to see patients more, and it's in their best interest to make people well and keep them out of the clinic. There are also specific incentives, whether financial or otherwise, non-financial incentives, to curb opioid abuse in their community. And so as this patient arrives, the secretary is also knowledgeable about these metrics and goals and vision that the clinic has. And the secretary has recognized that this patient has been in multiple times and communicates that to the other caregivers in the clinic. The provider, a nurse practitioner, who only recently had been trained and educated to be a physician. So she had been practicing in that clinic for over 20 years, had tremendous experience and knowledge as a primary care provider, and had excelled in that role. And there was a new, again, imaginary but ideal program. Let's see if, there we go. Program to allow her to take, let's say, a year or a year and a half to train in hospital medicine, intensive care, pediatric intensive care, orthopedics, so some medical disciplines that she might not have had exposure to in her clinic. But then instead of taking 7 years to become a physician, it only took her a year and a half. So she is now practicing and being paid. She's happy to be paid more than she would as a nurse practitioner, but she's also happy to be paid less than a physician because her training was much less, and long term, that's financially advantageous for her. So she sees this patient, and after the secretary notifies her of the frequent visits, she is able to convene a meeting with the patient's good friend, a religious leader, and a family member, and they all come up with a plan to help curb, along with a social worker, they come up with a plan to help curb her opioid use and focus on her well-being. So that's just a quick imagination. I think some of these are playing out on both extremes in our country right now, and so we need to find, identify, celebrate, reward those that are focused on health and well-being for all at the lowest possible cost, and we need to disincentivize those that are still focused on rescue treatments and incentivizing volume. I'd love to know your thoughts. I will be posting videos every day on topics related to health transformation. I'm hoping to contribute to or catalyze or create a discussion that leads to a critical mass of people and a tipping point to create the best health system in the history of the world. Thank you.